Lung infection in those hosts occurs with inhalation as few as 10 arthrochonidia. So where does valley fever or coccidioidomycosis occur? As I mentioned, autochthonous or local infection only occurs in the Western Hemisphere. And we can see this Western Hemispheric map. It goes from northern Argentina, Paraguay, Bolivia, northeastern Brazil, into Venezuela and Colombia, into parts of Central America, but its real endemic area is in northern Mexico and the southwestern United States. It's important to realize that where this fungus is really identified is in two areas, and that is California and Arizona. And if we look to the right, we see the CDC surveillance data where cases of coccidioidomycosis are reported to CDC. You'll see a big gray area because only 38 states report. But in those states that do, we see two highly endemic areas. And the first is the southern San Joaquin Valley, which is where the name valley fever comes from. The full name is San Joaquin Valley fever. And that's particularly Kern County with Bakersfield. But if we look at Arizona, we see it's concentrated in the south central region. And this is principally in Maricopa, Pinal, and Pima counties. And remember, Maricopa County is the county for metropolitan Phoenix, the fifth largest urban area in the United States. And Pima County has Tucson, which has over 1 million people. So the highly populated areas of Arizona are actually the endemic areas for valley fever. So valley fever the fungus has a unique life cycle, which it shares with several other fungi, and we call this dimorphic. And what that means is the fungus exists in the soil, in the environment, as a mold. But in the host, it changes. In the soil, it has tubular structures we call hyphae, which go on and septate, and intermittent cells degenerate, leaving single-celled, thick-walled entities we call arthrochonidia or jointed spores. Because the fungus can grow above the soil, these spores can be dislodged by puffs of wind and become airborne. When they are inhaled by a susceptible mammalian host, they change their form. In the case of coccidioides, they expand and round up, and they cause the structure we call the spherule. The spherule internally septates and forms smaller units called endospores. If that spherule ruptures and releases endospores, those endospores within the host can turn into more spherules. However, if those spores return to the environment, they turn back into the mold or mycelia form with hyphae. So the fungus can cycle between an environmental form and a host form. So in human infections, we're end stage, but our cycle is the same as any other mammal. We will inhale the arthrochonidia from the environment, and it will enter our lungs. And after inhalation, there's an intense inflammatory response, which can be neutrophilic, but also granulomatous. And this can result in a pneumonia, as we see. In a small number of cases, the fungus is not controlled and can spread throughout the body, and we call that extrathoracic dissemination. The key to controlling this infection is the cellular immune system. So it's really the host that controls this, and most hosts do control the infection. So this is what valley fever looks like. We know from studies that 60% of all infections are completely without symptoms. People get infected but never come to medical attention. The other 40% present with a pneumonia, and that can be a simple pneumonia, or it can be associated with certain immunological side effects, particularly rashes, and in some cases, joint aches. In a small number of cases, we think about 1%, that's when we see extrathoracic dissemination, and the other 4%, we see pulmonary sequelae. So out of 100 infections, 60 are asymptomatic and 40 have a symptomatic pneumonia. 4 of those will go on to have some pulmonary sequelae, nodules, cavities. Whoops. But most from these 60 and these 40 will recover and they'll be lifelong immune. So if they continue living in the endemic area, say in the Phoenix area, they will be immune and never have another problem again. As I mentioned, about 1 out of these 100 develop extrathoracic dissemination. So you might say, well, why are we so concerned about this? It seems like a very small number of individuals ever have any problems. And that's because there's new estimations about the impact of this disease. From state reporting, there are only about 20,000 annual cases reported. That's a relatively small number. But Centers for Disease Control, the mycotic branch, has been working for several years to try to really see what the true annual incidence is. And in this recently published work by Samantha Williams and her colleagues, they estimated that there are up to 360,000 symptomatic cases. And of those, 28,000 result in hospitalization and 1,100 deaths. So this is a far higher number than this 20,000 and far exceeds diseases like Lyme disease or West Nile virus infection. So valley fever, as I've indicated, frequently presents as a pneumonia and frequently presents what we call a community-acquired pneumonia, which by definition is a pneumonia acquired in the community outside of any medical setting. And it presents very similarly to bacterial community-acquired pneumonias, such as from pneumococcus or Legionella. Patients present with cough, frequently with pleuritic chest pain, and with a very abrupt onset. But there are characteristics of valley fever that are distinct from bacterial infections. And these I've put in 3 baskets. The first baskets are these unique symptoms that people present with. They present with profound night sweats, not so much fevers and chills, despite the name, but marked night sweats. They also have fatigue, and in the pneumonic syndrome, they have headache. We'll talk about rashes, which one really doesn't see with bacterial pneumonias, as well as weight loss and arthralgias that can occur. X-ray findings can be distinct from bacterial community-acquired pneumonias in that the infiltrate is often in the upper lobe, it's dense, and it's associated with hilar and mediastinal adenopathy. If one does a CT, one can see micronodules surrounding a larger nodule. And finally, and this often occurs clinically, failure to improve with antibiotic therapy is a key finding, because obviously antibacterial therapy shouldn't make valley fever improve. And a certain percent of patients have peripheral blood eosinophilia, another unique finding compared to bacterial processes. So here's a couple pictures of the rashes that one might see. Here's a toxic erythema. This could be like a drug allergy rash, erythema multiforme, but this is the one we want to focus on, erythema nodosum. And as we can see, this is a young woman with these violaceous raised bumps, and in fact, that's what they're called. And I can tell you, these are quite painful. Dr. Galgiani has found that patients tested, the most common cause of patients with erythema nodosum in Arizona is actually valley fever. So if one sees this kind of rash in association with a pneumonia in the endemic area, one should really think of valley fever. This is from David Ducato at Mayo Clinic in Arizona. This is Sweet syndrome, which is a neutrophilic infiltrating rash. Here's an example of a pneumonia, and this is classic for valley fever. Very dense, upper lobe pushing down on the major fissure with hilar adenopathy. This would be very unusual for a bacterial process. So if valley fever is a cause of CAP, how commonly does that occur? And there have been 3 studies, all done in a fairly close period of time, that have tried to look at that. And they've come up with an estimate that it's somewhere between 15 and 29% of community-acquired pneumonias in the U.S. endemic area are probably coccidioidal. So the first study was done by Lisa Valdivia and her colleagues in Tucson. They looked at 3 primary care sites during the winter of 2003 and during the spring and summer of 2004 among adults with a lower respiratory tract syndrome of less than 1 month duration. And this included pleuritic chest pain, shortness of breath, a chest x-ray that showed an infiltrate, multiple visits. They identified 55 patients who were tested for valley fever serologically. And among those 55, 16 were positive, which gave the 29% estimate and a confidence interval of between 16 and 44%. 11 of the patients had several serologic methods positive, and we'll come back to this. 84% of those patients received an antibacterial. In another study done by the Arizona Department of Public Health and CDC, Chang and colleagues did a retrospective study of 2 healthcare systems in Phoenix around the same time, January 2003 to December 2004. They used ICD coding for unspecified pneumonia and performed a case control study. They identified 60 patients with community-acquired pneumonia who had serologic testing for valley fever, and 9 of those were positive for 15%, with a range of 8 to 26%. Chest pain, rash, and symptoms for more than 2 weeks were more likely to be tested than other individuals. And finally, Kim and her colleagues at Mayo Clinic in Arizona looked at all adult patients admitted for CAP at that institution. And they did that from February 2000 to November 2004 and identified 59 patients. And again, 35 had paired serologic testing. They found 17% were serologically positive, between 7 and 34%. And a rash was a predictor of a positive serology. So that brings us up, how is valley fever diagnosed? This is a table from Dallas Smith from the Centers for Disease Control Mycotic Branch. I'm not going to go through all of it, but just to remind us that the testing for valley fever is serology. It is not antigen testing. And it is recommended by CDC that anyone with an unknown community-acquired pneumonia that doesn't respond to antibiotics should be tested, or anyone with an initial presentation living in the endemic area, particularly if they have a rash like enodosum. So let's simplify this a little bit. What steps should we take when suspecting pulmonary coccidioidomycosis? So this is in the context of presenting with a community-acquired pneumonia. You have cough, pleuritic chest pain, and an infiltrate on chest imaging. The first thing is to order serology, and the simplest serology to order is what we call enzyme-linked immunoassay, or EIA, for IgM and IgG. These are usually linked. These are generally available and relatively rapid. We'll come back to this. Results usually take 24 to 48 hours. If either are positive, then one wants to order the more specific tests. These are the immunodiffusion and complement fixation tests. If the test is negative, but you really suspect that this patient has valley fever, let's say the patient has a pneumonia, they have erythema nodosum, they're living in the endemic area, you should repeat that test. You can do it 5 to 7 days, you can wait longer, you can even do it sooner. You should go ahead and obtain a fungal culture, but one thing you could do, if you felt very strongly you saw this patient, you don't need to start antibacterial therapy because you have a very high confidence. If you have a patient with a pneumonia, with, say, enodosum and a positive serology, they probably have LE fever and not a bacterial process. And antifungal therapy is not always required because, as I showed you, many of these patients resolve their infection with time without any specific therapy. So we have a solution. We should test patients with community-acquired pneumonia who are in the endemic area. So how often do we do that? Well, Mohammed Khan and his colleagues at Arizona Department of Health Service did that in a paper published in 2018 based on emergency room visits from some years before. Among over 13,000 visits associated with CAP, only 3.2% were tested. Pima County had the highest testing rate, but other counties like Maricopa were never listed, so presumably they were lower. Chang et al., in that study I already mentioned of 2 healthcare settings in Phoenix, found that 2% and 13% were tested. Now you'd say, well, okay, but if it's really severe pneumonia, they're going to get hospitalized, and there everyone's going to get tested for valley fever if they have a community-acquired pneumonia. So we asked that question. We thought it would be everyone, but in fact, in 2 studies, one that Justin Hayes did, and I collaborated with this, he looked at 225 patients admitted to Banner University Medical Center, Tucson, for pneumonia. Only 56% of hospitalized patients were tested. Janice Blair looked at Mayo Clinic in Arizona, 1,162 patients, only 66% were tested after hospitalization. So what are the impacts of delaying the diagnosis? Well, this is a nice paper by Fariba Donovan at the University of Arizona, where she did a retrospective review of 276 patients with valley fever in Tucson. She found only 30 of those patients, or 11%, had a diagnosis made on initial visit, and 12 of the patients were diagnosed only upon hospitalization. Of the remaining 264 patients, there was a median delay of diagnosis of 30 days for a cost of over $500,000. But since we're talking about antibiotic use, there were over 1,100 antibacterials diagnosed or prescribed prior to the coccidioidal diagnosis. So a huge medical cost and a huge burden of antibacterials for a disease that doesn't respond to that. This study was sort of expanded by Jay Poo, looking at the entire Banner Health system from 2017 to 2019. And there they found nearly 73% of the diagnoses were made after patients got hospitalized. Only 22% were made in ambulatory care, 3% in emergency departments, and only 0.5% of the diagnoses were made in urgent care clinics. And remember, these are community-acquired pneumonias where patients are presenting to such centers for a diagnosis. Of those hospitalized, 41% really never required intensive care or hospital procedures, and they only stayed a median of 3 days. What this implies is they weren't hospitalized for illness, but probably because of a lack of a diagnosis. The median hospital cost was nearly $50,000 per patient for a total of $28 million. And once again, antibacterials were ordered in over 95%, 23,000 orders in 2018, 33 different antibacterials. And finally, Caitlin Benedict at the Mycotics branch of the Centers for Disease Control did this recent study of a Medicare database. This really just looked at cost, but we'll go through it. Again, there was a delay in diagnosis in 71% of the almost 2,000 cases. And again, that mean delay was 30 days. And for each delay, we could see costs go up. So what are the data on antibiotic overuse? I've sort of suggested it, but let's go through it. In a study from Centers for Disease Control and from Kaiser Permanente, Southern California, by Chi et al., 70% of patients who had positive coccidioidal tests were prescribed antibiotics before those tests became positive. I mentioned the Valdivia study. 84% of those individuals received antibacterials before the diagnosis. And Clarice Tsang and her colleagues at the Arizona Department of Health Service found in another study 60% of patients received antibacterial agents. On top of just receiving antibiotics, multiple courses were common. Why? Because valley fever can be a persistent disease. So Sarah Tartoff of Kaiser Permanente, Southern California, showed that patients with confirmed coccidioidomycosis were more likely to have received at least 2 courses of antimicrobial drugs prior to the diagnosis of valley fever. And again, in the Tsang study, 32% of that group received at least more than 1 course of antibacterials. So there's a huge burden of prescription and multiple courses when the diagnosis of valley fever isn't made. So how can we do better? Well, I would argue that this is a perfect setup for this new process we call diagnostic stewardship, which uses diagnostic testing as the first principle guiding antimicrobial stewardship, with the idea that appropriate therapy can only occur when the diagnosis is reasonably established. And it's a process of ordering, performing, and reporting to improve treatment. And the catchphrase is the right test for the right patient at the right time. This concept is relatively new. It was proposed by Morgan, Milani, and Dykema in 2017, and since then has been brought into the core elements of antimicrobial stewardship. The ideal diagnostic stewardship interventions, per Dan Dykema, are that it's built in the ordering, collecting, testing, reporting workflow, that it's minimally disruptive to that, but not easily bypassed, and acts to educate clinicians while improving selection and interpretation of tests. Now, you heard Kelly and Cho talk about antimicrobial stewardship. Diagnostic stewardship is separate and additive. And so we can see that antimicrobial stewardship starts once antimicrobials are initiated, but diagnostic stewardship starts with the ordering of diagnostic tests before that process. So in the perfect world, diagnostic stewardship is working hand in glove with antimicrobial stewardship to improve outcome. So how might we use diagnostic stewardship for valley fever? And these are my proposals. The first is to make serologic testing part of any community-acquired electronic medical record order set in endemic areas. That is, if someone in urgent care, the ED, or ambulatory care encounters a patient with CAP within the endemic area, serologic testing for valley fever would be part of the order set, as much a part as ordering a chest x-ray. Medical centers could establish coccidioidal serologic testing as a quality measure. So for example, those data I showed you on hospitalized patients, if that medical center encouraged quality measures, said we need to have testing when you're admitted for a pneumonia, for valley fever, we need that testing to be above 90%. That would encourage testing for those most severe cases. Because testing is complicated, and we certainly don't have time to go into this serologic test for valley fever, but this confuses many clinicians. So why not bundle the EIA, IgM, and IgG into a single screening test? And some centers have done this. So that's all the clinician needs to order. In addition, if that EI test comes back positive, laboratories should automatically reflects to the more specific immunodiffusion and complement fixation tests. So clinicians aren't dependent upon to do that. And in medical centers within the endemic regions, there should be a process to offer expert advice, particularly regarding serology interpretation, which can be difficult. And they should provide access to infectious diseases or pulmonary consultation. Finally, can we improve turnaround time of serologic tests to make this more usable? So one of the big problems is this turnaround time. The EIA test takes 24 to 48 hours. Immunodiffusion and complement fixation commonly take a week. And it's important to understand that urgent care and emergency departments tend not to order tests that aren't available during the time of the visit. Why? Because that patient has completed their visit and they've left. They've been prescribed an antibiotic, and now a day or two later, a positive test comes back. What to do? That engenders calling the patient back, reassessing the patient, and deciding on this new diagnosis. So are there tests that could be done within the time frame of the visit? And it turns out there are. These are called lateral flow assays. They are relatively rapid. They can be done in 30 to 60 minutes, and they can be done point of care. We actually have one currently on the market, and that's the SONA test by IMI Diagnostics. Unfortunately, Dr. Donovan did a study in Tucson and found it only had a 31% sensitivity, although it was highly specific. Another test called CTS1 is in clinical trials but is not available and looks to be far more sensitive. So we may have this lateral flow test in the near future. So how would that impact the diagnosis of valley fever? Well, first you could do a rapid point of care test. You could do that in the clinic setting and make the diagnosis there. The problem is point of care tests have been difficult to approve in that setting. Defaults are to do lab tests in labs. And in addition, it's an extra burden on clinic staff to perform. So you can imagine a busy emergency department. Now they have to devote resources, a nurse, a medical assistant, to obtain a finger stick, place it on the lateral flow, come back and read it. So an alternative is to perform the test in the clinical laboratory that has a rapid turnaround. And we have an analogy to that, and that's the troponin algorithm for anterior chest pain, where if a patient presents at high risk for coronary syndrome in an ED, they don't leave until a troponin has been returned. So if we could develop a lateral flow test for a pneumonia in an endemic area where the patient doesn't leave until that test has been returned either positive or negative, that should improve testing by a lot. Now, the final point I want to go over is how current guidelines for CAP affect antibiotic usage. Current guidelines are syndromic, not diagnostic, and this is a big problem. When I was in training many years ago, we were much more diagnostic. We would collect a sputum sample and make a gram stain. And frequently, we would come to a diagnosis. We could see gram-positive lancet-shaped diplococci and say, this patient has pneumococcal pneumonia. Now I know what the antibiotic is. But current guidelines really don't do that. And in fact, they often restrict microbiological testing. And they rely on empiric therapy that is often based on rather arbitrary resistance thresholds. They exclude certain populations, such as compromised hosts, but most importantly for this talk, they do not take into account geography. So they don't include the risk of primary pneumonia from endemic fungi, such as Coccidioides. Now, I haven't talked about it, but remember, we also have histoplasmosis in the central United States and blastomycosis in the central United States and into New England. But our guidelines don't ever tell us what to do when we practice in those areas. Here's the recent American Thoracic Society and Infectious Disease Society community-acquired pneumonia guidelines. They were written in 2019. They cover 16 issues. None bring up the geography or approach fungal pneumonias. An update was published in May 2025 covering 4 additional issues, but again, none regarding geography or fungal pneumonia. This prompted a group of us, led by Dallas Smith at Centers for Disease Control, to write a letter to say dimorphic fungal testing needs to be clearly specified in the guidelines for CAP due to high incidence and mortality. So, in summary, primary pulmonary coccidioidomycosis, called valley fever, frequently presents like a community-acquired pneumonia, but there are differentiating factors that can help distinguish these. In the endemic region, we think anywhere from 15 to 29% of cases of community-acquired pneumonia are actually due to valley fever. But testing is infrequent, only 2 to 13%. Lack of diagnosis of primary pulmonary coccidioidomycosis leads to overuse of antibiotics. We pointed out that in most studies, over 80% of patients receive antibacterials when they're not helpful, and multiple courses of antibiotics are frequent. Finally, I believe that diagnostic stewardship and rapid testing are possible approaches to improving identification and reducing antibiotic overuse in endemic areas where valley fever is common. I believe that's my last slide, so I'll turn this back over to Roshana.
Thank you, Dr. Campbell, for your great presentation. I saw some questions in the chat. I will address that soon, but if you have any questions, feel free to use chat or raise hand function to ask questions. Some of the questions we received in the chat is like, what about cancer patients or other immunocompromised patients who might be neutropenic? How do they present or what is their prognosis?
So patients with severe valley fever most commonly have suppressed cellular immune conditions. So the patients we really worry about is not so much neutropenia, but patients with untreated HIV infection with low CD4 cell counts, patients who are transplant recipients, patients who are on chronic corticosteroids. Excuse me. Less so are patients on biological response modifiers like TNF alpha inhibitors. So those are the immunocompromised patients we really worry about of having more severe and more prevalent valley fever. And those patients in the endemic area you really want to focus on because they may develop valley fever and it may be quite severe.
Thanks, Dr. Campbell. We have another question in the chat. Do you run an ID from like a Malitov and differentiate between other atypical pneumonias that are very difficult to clinically separate without an out ID step organisms like Mycoplasma pneumoniae or Chlamydia pneumoniae or even Legionella?
Well, great question, because all those require that you get a sputum sample. And current guidelines really discourage getting sputum samples. So the first thing to understand about valley fever is it grows very readily. It grows from 2 to 5 days. It's not and laboratories can identify it. They don't need multi-TOF to identify it if it's found in the sputum. It's not always found in the sputum, maybe about a third of the time. So that can be done if one obtains a sputum on the patient. But that's one of the problems with current guidelines. They don't encourage the obtaining of sputum samples to make a diagnosis versus a syndrome. So that's why we rely so much on serology. Remember, for histoplasmosis and blastomycosis, we actually get urinary antigen, which is probably a better test, but it just doesn't work very well for valley fever. Coccidioidomycosis, particularly the pneumonic syndromes, the antigen tests are rarely positive. So we might do better if we had a urinary antigen test that was more frequently positive, but we don't. So serology is still the fastest way to diagnose it. Yeah, I can do the next question because the Coxi antibody test from SonoraQuest. I'm not sure if that's SonoraQuest does do EIA, IgM, IgG, and in fact, they are the most common laboratory provider in Arizona because they're the laboratory for Banner, which is a very large healthcare group. So that's where you would start, and SonoraQuest would start with the EIA test. It just depends on where you practice, what they call these tests. Um, so if where you are, SonoraQuest bundles an IgM and an IgG, that's the place to start.
Thank you, Dr. Ample. Thank you for letting me know that I was muted. One question I have is what is the impact of unnecessary antibiotic use on the risk of adverse events such as C. difficile infection in patients with valley fever?
That's a great question, and I couldn't find any data. It was hard enough. I think that currently we haven't focused enough on the antibiotic overuse. Most of it has been cost use, and that's what you see in most of the papers. And the antibiotic overuse is a secondary phenomenon. So I don't know of any impact papers, for example, showing that when one does this, increased risks of, for example, a C. difficile infection or antibacterial resistance. Be a great study to do to look at patients who've received multiple courses of antibiotics, antibacterials for coccidioides. What are those impacts on other infections and on antibacterial resistance? But I don't see any studies. Those are the only studies I know which just really report the antibiotic overuse and the multiple courses.
Thank you, Dr. Ample. Anyone has any other questions for Dr. Ample?
Yeah, I'm just going to comment because Stacy said absolutely. SonoraQuest offers everything. And that's true. And it just depends at your facility how those are bundled. Some places the clinician is offered, the EIA, and then the facility may reflex automatically to immunodiffusion and CompFix. In other places, it's up to the clinician to do that. But SonoraQuest does all the testing and does a lot of testing.
I'm not seeing any questions in the chat and anyone seeing any raising hands. Thank you all for participating in our day one AAW webinar series.